Our next guest is Dr. Lina Winn. She's an emergency physician and public health professor at George Washington University. She's also a contributing columnist at the Washington Post and a CNN medical analyst. I first came across her a few years ago when she came to speak at a couple of our programs on the opioids crisis, because at the time she was commissioner of the city of Baltimore, health commissioner for the city of Baltimore, and came on to describe to our fellows some of the innovative strategies that they were using in Baltimore to attack opioids. In the last couple of years, she has become a really a must-read medical columnist, medical journalist. And she's had some really good columns about kind of what needs to be covered more and needs to be covered differently in the COVID pandemic right now. So I asked her to come and talk kind of loosely about what sorts of things would she like to see covered differently or covered better on COVID. She's going to talk for a few minutes, for 10 or 15 minutes, and then we have time for questions. This is a shorter session than before, but we also don't have a hard stop on it because the session that follows is kind of fungible. We can take some time for this last session of the day, which is just me talking over some data and passing on some data sources that you might use for COVID. So if we have more questions for Dr. Winn, we can eat into that time. But with that, I want to turn it over to Dr. Lina Winn.
Thank you very much, Chris. It's a pleasure to join you today, and thank you all for inviting me. I'm really looking forward to a conversation, and so I had written down a few things I wanted to give you to the topic that Chris mentioned. I wanted to give you 3 things that I think should be covered more when it comes to the vaccine rollout, especially for people who are doing reporting on the ground. And then I also wanted to just give you a kind of a smorgasbord of issues that I'm watching out for, and I guess things that I would recommend that we all covering or analyzing the COVID crisis can be looking out for. So, all right. So the 3 things that I think we should be covering more, and I know that you've also had some really good speakers and panelists. I caught the end of the last panel, and so it's possible that they also mentioned this, and maybe you are all covering this a lot. But anyway, the 3 things that I think should be covered more. One is the real benefit of the vaccine. And I think specifically that we should be really covering and talking about the endpoint that really matters, which is not the endpoint of preventing symptomatic disease. I know that's how it's been covered. Pfizer, Moderna, we keep talking about 95% efficacy. Well, now we've seen the issue with Johnson & Johnson, that 72% effective in the US, maybe 66% if you're looking at that preventing some kind of symptoms. But I actually think this is totally not the right endpoint. People don't care really if they're going to get the fever and the sniffles. Certainly, we're not going to close down the economy and prevent kids from going to school because we're trying to prevent a mild cold or even a mild flu. What we care about is severe disease, and specifically disease that's severe enough to cause hospitalizations and deaths. And so that's the endpoint that we should be talking about. And actually, all of these vaccines are essentially 100% at preventing hospitalizations and deaths. I think something else along these lines is the real benefit of the vaccine when it comes to resuming our normal lives again. I wrote a column last week, actually, saying that the CDC needs to provide much clearer guidance about what you can do once you're fully vaccinated. Because I can tell you, as a practicing physician, I hear from my patients one of 2 things, both of which are very troubling. One is people saying, well, I'm now vaccinated. I'm going to go to a bar. I can't wait to take off my mask and travel around the world. And, that's obviously not the right message either, because we don't fully know the answer to this question of, are you still a carrier of coronavirus? So that's not great. But I think equally not great is people saying, I don't see the purpose of taking the vaccine. If I can't do anything differently now that I'm vaccinated, what's the point of doing this? And because vaccine hesitancy, I truly believe is going to be the main reason that prevents us from reaching herd immunity and putting an end to this pandemic. I think we need to get a lot better about talking about the freedoms that people have once they are vaccinated. And those freedoms, I think, include seeing other fully vaccinated people who are, again, both parties fully vaccinated, being able to be indoors, no masks, hugging them, no restrictions, essentially, with other people who are fully vaccinated. I think we should be telling grandparents that they are fine to see their grandkids. Is there a chance that the grandparents could somehow infect the rest of the family? Sure, but that chance is pretty low. And I think at this point, we need to move on with our lives and allow people some degree of normality. So that aspect of what is the benefit of the vaccines, I think we can cover more. Second bucket of things that I think we should cover more is, where are the vaccines? Okay, I've been beating this drum since the very beginning. I think we need two different types of tracking systems for the public. One is tracking of where in the manufacturing process are all these doses. The second is what happens when all these doses are given to the states. So taking them one by one, it seems like there's a constantly moving goalpost. First, we hear a certain amount will be delivered by this company, by this state. Then we hear it's actually a smaller number. Then it seems to be increased again. I can't keep track of this as someone who's thinking about this day and night. And I think a lot of people cannot either. We as taxpayers have quite substantially funded the development and distribution of these vaccines. I think we should be entitled to see on a week by week basis where exactly are the projections for vaccines at all times. Is Pfizer projecting X amount by today, by next week, Moderna, Johnson & Johnson, and so forth? That allows states better visibility too. Second and related issue is what happens once the doses are given to the states. I think there should be a very specific tracking of these vaccines that allows us to also hold certain entities accountable. For example, let's say that 100 doses are given to 2 different pharmacies. One pharmacy is able to use up 100 doses in 2 days. And the types of individuals that they're vaccinating are also people of color, individuals in low-income areas. Another pharmacy may be holding on to the doses and after a week still has 50 doses. In that case, we should be reallocating the doses from the pharmacy that's not doing such an efficient job to the pharmacy that is. Similarly, we can see, are hospitals doing good work? Are federally qualified health centers? What exactly is happening? That type of real-time tracking, I think, is essential for efficiency, for accountability, and actually, if our goal is both speed and equity, that type of real-time accounting is really necessary. I fear that now there are just too many cooks in the kitchen and that no one is accountable, as in the federal government is now directly allocating doses to FQHCs and to pharmacies. Who is ultimately in charge? Who is saying this pharmacy is not that efficient and this other one is? We're going to reallocate. I really believe in this use it or lose it system. Lowest common denominator is not the same thing as equity. Third issue that I hope that we'll focus more on is success stories. I've been talking about some of the problems that there are, but you all, as people who are covering this every day, you know that there are actually really good stories of vaccine rollouts. And I'm sure you heard this in previous sessions about outreach, for example, door-to-door outreach, the vaccination pop-up clinics that are occurring in churches where community leaders are really acting as the trusted messenger to get out the word. I was listening to the White House briefing today. I was doing the before and after response for CNN, and so heard the announcement in real time that Andy Slavitt made about public-private partnerships. And it sounds like Uber and Lyft, as an example, they are partnering with various pharmacies to provide rides for free. There are also great partnerships that have ensured mass vaccination clinics really take off, and businesses are now going to also be helping to put out the message about how vaccines are so essential. I mean, I think we need to hear a lot more success stories like that. First of all, because I think a lot of people want to do the right thing. A lot of businesses, community groups, local health departments, they want these best practices. And so elevating those success stories will help them. And I think it also just gives us more hope too, because I think hope is something that we've been lacking all along during this pandemic, and giving a bit more hope about what we can expect will be really important. All right, so I'm now going to give you, these are my 3 things, right? The importance of the real benefit, covering where the doses, and success stories. I now want to give you a random listing of stuff that I think is going to come up. And again, happy to talk about any of these things, but just random listing of things that I think will need to be covered a lot more. Testing. There are now a lot of tests that are out there, but why is it that testing has actually decreased, and yet test positivity is above 5% in many parts? What's going on with testing? Are we really deploying these antigen tests? How are we thinking about antigen tests versus PCR tests? I have an opinion about this that I also wrote a column about, but I want to hear from the federal government what exactly is happening. Okay, second, schools. My most recent column was specifically about this, about the issue of schools, where I said, I think both sides of the reopening debate have been framing the issue the wrong way, because we're never going to agree on the issue, frankly, of whether schools are safe. We're just not going to agree. Some people think that some level of safety, as long as the level is below the transmission likelihood in the community, is safe. That's fine. Other people will say, unless you have zero risk of transmission in school, I'm not sending my child, or I'm not ready to go back. And so I think we need to completely reframe the issue and instead talk about how schools are essential, just as doctors' offices and hospitals are. But anyway, happy to talk more about that. But that's going to be another issue. I think the third issue that we're going to see is, and that we are seeing, is what is happening right now. I think we are going to be in limbo for some time to come, where there isn't a clear answer of where we are. Look, if you were to ask any public health expert in December what was happening, I think we would have all had a clear answer that it was a terrible time, massive surge, Christmas coming, New Year's coming, really dangerous time. What's happening now? You're getting different answers from different very credible public health experts, all looking at the same data, but coming up with different interpretations. And I think that's going to be the case for the month to come, because is it that we're going to have lots of vaccinations, warmer weather coming, or is it that the variants are taking over? Where are we in this? I think it's going to be, we're in limbo for some period of time. I worry about the complacency also that's going to occur over the summer. And even if we avoid a fourth surge now, might we see a fourth or fifth surge come the fall if we don't reach enough people to get vaccinated over the summer? That's actually my big fear. That I heard at the end, you were asking, I think Dr. Plesha or somebody else, about, are we going to have enough supply at some point? I think we are going to have enough supply, at some point pretty soon. The demand is going to catch up with supply. And then we're going to be fighting this battle of vaccine hesitancy. And my fear is that things will be good enough over the summer that people really let down their guard. And as a result, we have a major problem going into the fall of not having enough people vaccinated. And the last issue that I'll flag, that I'm sure we are all thinking about, is vaccine passports. If we're talking about the freedoms that people will have, what is the carrot? Are we going to have this green passport that Israel just has? I was just listening to the story on NPR about this. Are we going to have that? Is there going to be a backlash? What is the carrot and the stick that's going to be involved that our country will tolerate? Anyway, I've been talking a lot, but I look forward to your questions.
Okay, so we have time. This is mostly Q&A. We have time for questions. We're going to go to Jarvis first, and then Laura Bischoff second. So Jarvis.
Hi, Dr. Winn. Can you hear me?
Yes.
Yep.
Making sure. I was just curious as to know what you mean when you say the lowest common denominator is not the same as equity. Can you explain what you meant by that?
Yeah, so I, having worked as the health commissioner in Baltimore, which is a city that is extremely underserved when it comes to healthcare access, I'm very concerned about how the disparities that we have known for a long time are unveiled, unmasked because of COVID, right? That we all know it's not the virus that's doing the discriminating. It's our systems that are in place that are such that, for example, in Baltimore, 1 in 3 African Americans live in a food desert compared to 1 in 12 whites. Any surprise then that African Americans in Baltimore have a much higher likelihood of having diabetes, high blood pressure, heart disease that then also predispose to COVID? And I mean, you all know this, but I'm just saying, I'm very attuned to this particular issue. I think the way to address equity, actually, the Biden administration is doing a lot of things right in this regard, because, for example, they are having doses that directly go to federally qualified health centers. They are looking to see which pharmacies are in areas of highest need of individuals who are not currently getting vaccinated, or having mobile vaccinations. I think is so important. I was the health commissioner in 2015 following the death of Freddie Gray while in police custody, when we had, for example, over 12 of our pharmacies that were burned down or closed. And I saw how much people depended on their pharmacy for food and were not able to get even, half a mile away for many people. If you're in a wheelchair on oxygen, how are you supposed to get that half a mile away to get your necessities? And so going door to door is really important, and going to where people are is so critical. What I mean with specifically the lowest common denominator issue is that I think the Biden administration is hesitant to reward institutions, entities, and states that are particularly effective at giving out vaccines. I think that we should be, again, tracking. And when you track, you can also set certain benchmarks. For example, maybe as one of your benchmarks, you say that if you have vaccination drives in a particular area, the people that you vaccinate should at least mirror the composition of the community that's around it. We have seen all kinds of reports from around the country of how it seems like a vaccination clinic set in a majority Black area has majority white people going to it, or low-income area has majority high-income people going to it. I mean, you can set metrics so that you are still saying, okay, this place is not, even if they're vaccinated a ton of people, they're not vaccinating the type of people so that we have an equitable kind of distribution. That's not good. But I still think that competition is a good thing, that we should be rewarding those entities that are able to vaccinate both quickly and equitably. We can set those metrics, but I think the Biden administration has been really afraid to set that kind of competition. And again, that's where I think they're confusing things. They're doing a very good job when it comes to equity as a metric and as an outcome. But I think they can also actually have competition to have even faster and more equitable types of distribution too.
All right, Laura Bischoff.
Yes, Doctor, thank you for taking this question. I'm Laura Bischoff. I'm a reporter for the Dayton Daily News in Ohio. Can you give us your thoughts on states that are moving legislation to dilute public health authorities, what that risk is during this current pandemic and other public health emergencies? And also, you mentioned vaccine passports. Given the political pushback that we've seen on masking, how do you think passports might go over with the American public?
Yeah, this is really interesting. I don't know the specifics of the regulation to your first question about what type of authorities that they're trying to remove. So I wonder, actually, Laura, do you mind telling me a bit more about the types? What exactly is happening there?
Sure. A number of the fellows in this group have talked about this is happening in multiple states where, in Ohio specifically, the legislature is more conservative than the governor and has introduced multiple bills that would require legislative oversight and basically veto power over public health orders. There's been a big pushback among conservatives saying that Governor DeWine has been too heavy-handed with shutdown orders, and that then that would be mitigated with oversight from lawmakers.
I see. I mean, I would be very concerned about that. I think that, public health emergencies, and I can tell you this from the local perspective, they happen, when they happen, they are emergencies. You don't have time to be going to the legislature, having long debates about the topic, including by individuals who are not experts in this. Now, I'm not saying that there isn't time later for review. Right. I mean, I think it is reasonable for the legislature in time to look back and say, okay, this maybe this was too heavy-handed to begin with. Maybe we now also need to weigh the pros and cons, because not, from a purely infection control perspective, you would actually just shut everything down until we get 0 cases of COVID in the country, right? That's if you're purely using infection control. That's not realistic. Actually, I've written about how we need to stop talking about shutdowns, and how even the word shutdown actually gives too much fuel to the if you will, to the people who are anti-masking and other things, saying, oh, well, look at these people, they're so extreme. So I think there is a time and a place, and it's appropriate for there to be an evaluation of the public health measures that are put into place. But I think taking away the authority of the executive government, of the executive branch, and specifically the public health authority to implement those measures in the first place, is really dangerous and will impede the ability to respond even to routine issues like Legionnaire's disease and tuberculosis and other things that that health departments have had to do on a regular basis anyway. There could be these downstream effects that are unexpected. To your other question, Laura, about vaccine passports, I mean, this is one that I'm really interested in, because I don't know that we have a good historical precedent in this. And I've been actually very interested listening to ethicists and lawyers, neither of which I am, but listening to other people talk about this and how this might play out. And I actually think that the example from Israel and also from the UK and other places that are further ahead of us are going to be really instructive. I think that until we are able to get to the point that everybody who wants a vaccine is able to get a vaccine, the vaccine passports are not really going to have a lot of legs. For example, you can't really imagine a restaurant or movie theater or something else doing that now, even though there was just a column or an op-ed in the Washington Post last night or this morning about how we should be, it was very interesting. I don't know that I agree with it, but just saying it was interesting, this idea of allowing restaurants to open at 100% capacity, but only for people who are fully vaccinated. It's an interesting thought, but could this actually happen now? Maybe not, because not enough people have been vaccinated. I think at some point, though, it's not unreasonable to envision a situation where cruises, for example, say, we're only going to allow people who are fully vaccinated to join the cruise. Or for certain other types of high risk and high investment type of situations, right? You're paying many thousands of dollars to be part of a cruise. I could actually imagine that happening more and more. And to the extent that it's actually facilitating businesses coming back, I think it's different from masking, because I think you might see businesses understanding this as a positive incentive that allows them to come back. And if we can frame it that way, I think it will have, it'll potentially open up a lot more avenues.
Thank you.
Dr. Winn, so do you have a hard stop on this? How late can you go?
I can go until 2.
Okay, good job. So we have up next, we're gonna have Barbara, then Lucille, then Coyote, then Gabriella, and then Jill. So Barbara
okay,
next.
good. I was like, is anybody going to have questions? Great.
Hi, my name is Barbara Rodriguez. I'm a State House's reporter for the 19th. So I'm looking at things from a national perspective a little bit. And I'm curious because we have had a little bit of this conversation about, various pieces of legislation moving through state houses that could be detrimental to public healthcare. I'm curious if you have any thoughts on what role a state legislature should be having right now. Obviously, there is a federal response to the pandemic that includes federal aid. And I'm thinking a lot about what that looks like on a state level in terms of, a certain number or figure that a state should be allotting as part of the federal response, or whether there should be some other type of policy that a state legislature should be enacting in response to the pandemic that would be good for public health. I don't know if there's, an interesting bill you've seen in the country or just something that is playing out in the state house that should be a part of this federal response.
Yeah, it's a really good question. I will tell you that in my experience personally, but also in my conversations with my public health colleagues around the country, I think one challenge has been that health departments are so overwhelmed, as all of you know very well, right? They were so underfunded before, they're so overwhelmed now. You probably won't hear this complaint from a current health director themselves on the record now. You can hear from me because I don't, I'm not reporting any individual person, but I can tell you this is something that other people have certainly experienced, is that state legislatures are asking, because this is the number one issue, understandably so, state legislatures are asking for testimony and all the time bombarding them with requests for things, data, responses. I understand that legislators want to seem responsive to their constituents, but I think it adds a whole additional level of work that may not always be helpful. So I actually think that less is more in some ways. I don't mean to be facetious here. I think that legislators can do a lot of good. It's just that I understand that the need to do something, and sometimes the doing something ends up overloading the executive branch in a way that's not necessarily helpful at this time. In terms of what I actually think would be helpful, I think is data oversight. I really think that, again, I keep on banging this drum and nobody seems to listen about this data tracking issue. But if there were actually tracking, I mean, that's something that I think would be really reasonable for legislators to be asking of the executive branch. Where are these doses? Are they being, what is the wastage level? I'm concerned about this. Why are we to this issue of lowest common denominator that I talked about before. I think that we should be holding entities accountable if they are slow at administering doses and if they are wasting doses. Why can't we know? If there's a pharmacy that uses 100 out of 100 doses, great. What if there's a pharmacy that uses 90 out of 100 doses? We should be investigating that and understanding what's going on with their practices. That's something that I think state legislators can actually be demanding and assisting with.
All right. Next up, we have Lucille.
Hi, thank you so much for this. This has been really helpful. I was going to ask this of our last guests, but I think you might be better suited to answer this question. So I've been reading a lot, really at a national level, about how especially the Biden administration isn't being very optimistic when we talk about vaccinations, kind of like you were saying. And it makes it really hard to cover that whenever our public health officials aren't being optimistic and we're talking about all of the caveats with vaccinations. How do we reckon with that? I have a hard time knowing. I don't want to go too far optimistic and too far negative. So like, how do I reckon with balancing kind of those things?
Yeah, Lucille, you ask a really good question. And I wrestle with this messaging every day as a clinician too, because I also want to be talking to my patients about the benefits of vaccination in a way that's real, right? I mean, I have to give science-based, accurate information, but I also want to be encouraging people to get vaccinated. I mean, there's even if you don't, and I think it comes down to this. I am comfortable giving advice and guidance based on what we know, understanding that there are still things we don't know. And I know that our patients, I am 100% certain that our patients will understand that too, because that's what we do in our daily lives on any other issue, right? If I'm advising a patient on cancer treatment or on taking a medication for their blood pressure or whatever, there's no guarantee that it's going to work. There's no guarantee that it will work on this person as it does on everybody. I mean, medicine is full of gray areas. So I actually think that clinicians know how to communicate this to our patients. We should be allowed to do that with the guidance and general framework of the CDC. And so what I say to my patients about the benefits of vaccination, understanding again, there's stuff we don't know. We don't know about being a carrier. And I mean, I think there is accumulating evidence that you are probably going to have a substantially reduced viral load, probably will not be as likely to be asymptomatic and to be infected asymptomatically. I mean, I think we do have enough information to say that. But I would feel very comfortable saying to my patients, you should get vaccinated to protect you, to protect others around you. If you get vaccinated, you will be it will reduce substantially, essentially to zero, your chance of getting severely ill to the point that you're hospitalized or die. That's really important. Also, it now allows you to see your family, to see your loved ones that you haven't for a year. If you really want to go to a restaurant, you can go to a restaurant. Don't rip off your mask and go to a different bar every night, but you can resume many of the things that you want to do. And if enough people get vaccinated, that's also what allows us to end this pandemic. I think we can give that kind of positive message that's still accurate. And I wish that the CDC would step up and do this too. I really think it's overdue for them to provide the kind of guidance for everyday life. They were late under the previous administration in providing guidance on masking. They were late in providing guidance for testing, which frankly, we still don't have yet. They were late when it comes to aerosols. I mean, remember when they came out with the guidance on aerosols, it was kind of like, yes, we've been saying this for months. Thank you for coming to the table. And so I want to see them step up more.
I just have one follow-up. It sounds like what you're saying is, instead of saying things are going to be fine in 6 months, which is kind of what I think people want to hear, like, when are we going to get to go back to normal, to say like, here are the things we can be optimistic right now and in the near future. Is that what you're saying?
I think we should frame it more of the individual. I think what people want to know is actually that. I mean, yeah, I think a lot of people may also want to know about society and when is it going to be that none of us have to wear masks or whatever. Maybe, I mean, I think some people want to know that too, but I actually think that most people want to know, this July, can I attend my cousin's wedding that has 50 people? This September for Labor Day, can I have a family reunion on whatever, the beach that I always do? I mean, whatever. I think people want to know, can this fall, can my kids go to school 5 days a week? I think that's what people want to know. And I actually think that we can give people pretty good answers about those things. If you're vaccinated, if you yourself are vaccinated, I think actually we can say yes to all those things that I just mentioned.
All right, next up, Coyote.
Thank you, Dr. Winn. My name is Coyote from Jackson. I work with Jackson Free Press in Mississippi. I would like to have your insights on the future of testing. How do you see testing, the place of testing as the months or weeks go on?
Yeah, Coyote, it's a really good question. And I actually think it's something that we have not answered as much. And there are some nuances here that I have not seen anyone report on. So maybe you can be the first ones to write about that. Well, it's probably, I'm sure it's not true that no one has written about this, but I just haven't seen this written as much. There's certainly going to be a role for testing because there are a lot of people who are not vaccinated. We still have to pick up on infections. And very critically, even for people who are vaccinated, they could still become ill. And to figure out this question of, are people who are vaccinated still carriers capable of infecting other people? We have to still be doing very careful testing and contact tracing. That's actually the only way that we'll know the answer to this question. Because if you find out that someone got infected, you contact trace, then you figure out that the only person who could have infected them is someone who was already vaccinated. That's the real answer to that question. And so, so there's definitely a role for testing, contact tracing, quarantining, everything else going forward. Here are three things, I think in threes. So here are three things that that I think are unanswered to me, and that I would like to see some kind of better clarity around. One, I mentioned already, which is we have antigen tests and PCR tests. How are we using them? I think the following, and again, I wrote this column last June, but is still, I think, true now. Antigen tests, I think, are a screening test. PCR test, I think, is the confirmatory. So I think what we should be doing is to say people who are asymptomatic, who are low risk, who just want to get a test because maybe they want to get together with their friends, you get the antigen test. Or you're at a school, the school is screening everyone, and you happen to be one of those people getting screened, but you're low risk, you were not exposed to somebody, you have no symptoms, you get the antigen test. If you test positive, or if you have symptoms, or if you were exposed to somebody who has coronavirus, you're high risk, you get the PCR test. That type of testing, thinking about testing, is how we do the rest of medical care. You know, you don't go, if somebody has a heart attack, or sorry, if somebody has a chest pain, you don't say to that person, you need to have a catheterization, the gold standard test. That doesn't make sense. But if that person, maybe this is a bit too esoteric, but bear with me for a moment. If you're 30 years old, you have chest pain, probably you might get an EKG as a start. Maybe you get some blood work as a start. You're not going to get a catheterization unless those things are really abnormal. On the other hand, if you have a history of multiple heart attacks, you have chest pain, maybe you're going straight to the catheterization without running on a treadmill. You know what I mean? Like I think it actually makes sense to say people who are low risk get this test, people who are high risk get that test, and we should be doing that. But okay, so that's number one. The second thing is some of the variants that are developing. The FDA actually put out an advisory saying that it's possible the tests that we have may not be picking up on these variants. I don't mean in terms of sequencing the genome, but rather that it's possible that our tests are saying you're negative when actually you're positive to some of these variants. I think we really need to be watching out for that. And then I think there's a third issue that I also just have not heard anyone talk about, but this is really where we do not have data. And so, but this is still an unknown, is could you be infected, but not infectious? So let's say that you are fully vaccinated. You get a test that says that you are positive. Is it possible that you could carry the virus in your nasal pharynx, but not be capable of infecting somebody else? We don't know the answer to this. And I think that also really changes things, because if you're fully vaccinated and you're still getting tested, Could we be picking up on all kinds of asymptomatic infections and then telling you to quarantine for no reason if that's the case? So I think that's something else to be watching out for when it comes to testing. I may have way over answered your question or under answered it, Coyote, so you'll have to tell me.
All right. So next up, we have Gabriella.
Hi, I work for Kentucky Educational Television. My question is about vaccinating prison populations. I know different states have handled that differently, and there has been pushback in some states about prioritizing the population. Other states have done it. In Kentucky, there hasn't been like a clear strategy. My question is, like, what are some challenges for vaccinating inmate populations, and what's the way of covering that? As a journalist. That's it.
Yeah, it's a great question, and one that I think touches a lot of nerves, right? It's one that goes to the issue of equity and to value that we hold in society, of do we value certain people differently? And, you know, is one that, you know, I and many others, I'm sure, have strong opinions about. But, you know, I think there's an issue that actually goes to the heart of this in a different way, which is that people also have strong feelings about, do you vaccinate older people or essential workers? And I actually think it's the same question, because that's still a value in society. Is our value that we want to cut illness, hospitalizations, and deaths, in which case you vaccinate older people? Or is it that we want to prevent the spread of disease and allow our economy to come back, in which case you vaccinate essential workers? Prisoners, if you think about it, is kind of in that second category too, of if your goal is to prevent infections, then your goal is also to vaccinate people who are in congregate living areas too. And so I don't have an answer here. I would just say that I hope that the answer to the prisoner vaccination question doesn't then remove the impetus to also release the nonviolent offenders who don't need to be in prison, because that was a push prior to when vaccines became distributed. And I think that that should still be something that from a society, public health, and criminal justice side also needs to be stated too.
All right. Next up, we have Jill.
I'm Jill. I'm with a statewide public radio program called the Texas Standard at UT Austin. Something that we've kind of been having conversations about editorially is, like, when vaccine efforts started ramping up, it was very contingent on internet access, and if you had access to like a cell phone or a computer. And I feel like that kind of opens the door to the equity issue still. And I'm wondering, you know, if you have any examples of public health programs at the local or state level that are working around that and not making it so that your opportunity to get a vaccine is contingent on whether you have that access. Because I feel like, at least here in Texas, it has the potential of disproportionately affecting, you know, low income and elderly and rural people.
Yeah, Jill, that's a really good question. And one issue that I think I had mentioned earlier, but I just wanted to make sure to really flag that upsets me a lot is when the statistics were released about who is getting vaccinated. And it looks like it's a lot of white people, you know, and higher income individuals who are getting vaccinated. One narrative that I heard a lot of was, oh, well, the other populations there's more vaccine hesitancy. I think we are confusing hesitancy with access, and hesitancy is being used as an excuse when access is actually the problem. Don't get me wrong, hesitancy in minority communities is really real, and we need to be addressing this issue too. But I get concerned when hesitancy is used as an excuse for why we're not doing better outreach. And when there are actually barriers that are standing in people's way, and we're saying, well, they don't want it. maybe they don't want it because they don't even know about it. Maybe they don't want, maybe they're not getting it because they don't have a way to get the transportation, or as you were saying, Jill, with technological access, maybe they can't sign on 200 times in an hour to try to book an appointment. Like, there are real reasons as to why people are not getting the vaccine. And so, what I've heard anecdotally, I've heard of church groups and neighborhood groups that are that have young people who are helping to sign up older individuals. I mean, I think that's really wonderful, and I would love to hear more of these personal stories. I mean, we have heard some of these stories of young people setting up coding websites, and I mean, I don't know how to say it, but like apps or whatever, but but also they're just people who are doing this work for their neighbors and people in their community, which I think is really wonderful. The other aspect here, I think that's going to be great, is door-to-door outreach. And specifically, at the time that I'm particularly enthusiastic about the Johnson & Johnson vaccine, and disclosure here that I am a volunteer in that trial. I don't know what I got, so that's something that I personally am looking forward to finding out what vaccine or not that I got. But I'm enthusiastic about the Johnson & Johnson vaccine because, as you know, it's one dose, stored very easily, transported very easily. And potentially you could go door to door, tell people about the vaccine, give them vaccines in their homes. I don't think we've talked so much about what do you do with homebound individuals or people who can't, why are we ordering an Uber for somebody to go to a Walgreens? Why don't we go to them? And so anyway, I think that's an aspect of access that we should talk about more.